Good evening, everybody, to Sagar and Esther teaching program. We have Naz Sheikh today, who is giving a talk on a very interesting and very ambiguous topic. And Dr. Kalaivani, Professor Kalaivani from MS Ramaya Medical College will moderate the session. I'm sure a lot of discussion will happen and also postgraduates will benefit from this. All the best, Dr. Kalaivani.
Thank you, sir. Thank you. First of all, I would like to thank Dr. Shivram and Dr. Lakshman for starting such a wonderful teaching program. And thanks for this opportunity for me to moderate the session. And I welcome the guest lecturer, Dr. Naz, who is a laparoscopic surgeon and works in her own setting. She's a senior surgeon. We are very much interested in academics, and I've also seen her doing all interesting and daring surgeries. She has presented her videos in various conferences, and Dr. Shrikant was so impressed. I remember him commenting to me, "See, she's done such a great job." Sir, I'm telling it today in the presence of both of you. And so we have all praises for Dr. Naz. And very special thing about Dr. Naz is she is also a poet. You give any topic or give any situation, she'll give an instant poem, which is about, maybe it'll come to more than 20 lines. I really wonder how she gets all these thoughts and so much in, the thought flow is so great. So we welcome you, Dr. Naz. And I welcome all the delegates, and most of them are postgraduates. I welcome Dr. Shenai, Dr. Shrikant, and Dr. Mahesh is there, Dr. Vidyadhar sir. All the students, I request all the students to be present here, and we can ask questions. Please feel free to ask questions. This is a platform that has been created by Dr. Shivram and Dr. Lakshman for you exclusively. And so please feel free to ask questions, and let it be an interactive session. Let it not be just be on one side. So please ask questions based on the cases, and don't hesitate to make mistakes. This platform is for mistakes and it's to be corrected. Okay, so I hope there will be a good participation from the students. So the topic, as you all know, it is granulomatous mastitis, which is a rare condition. Before Dr. Naz starts her lecture on this, I will just ask one or two small questions from the PGs. Now, I present you with a patient, she was about 32 years old, and she presented with an abscess during the lactational period, during which time she had undergone an incision and drainage in a nearby nursing home, and then it healed. Then subsequently, after 6 months, it recurred probably, and again the procedure was done and it healed. Then the third time, she came with multiple sinuses on the breast. This is a real case scenario. She came with multiple sinuses, a young lady, 32-year-old lady, and she presented to me. So when she came with, this was the very first time when I saw a case like this. So multiple sinuses on the breast. So the first thing I thought of was some kind of chronic abscess. What were the differential diagnoses you will think of, the students? The PGs, please. And then over to Naz. You just tell one or two diagnoses and Dr. Naz will take over.
Dr. Kalaivani, can they put in the chat box and then
yes, sir.
Take it later?
Okay, fine. Please put it in the chat box.
Fine, put it in the chat box. They need not even talk also. Then Dr. Naz will continue. Then in between, we'll take up those questions.
Okay, okay. Dr. Naz, please take over. Yes, sir. We'll do that.
Thank you, Dr. Kalaivani and Dr. Shivram sir, for those kind words. And I thank Dr. Lakshman sir and Dr. Shivram sir for this wonderful initiative. First of all, am I audible?
Yes, you're very clear, very clear.
I thank all of you who are present here today. I recognize the presence of Dr. Vidyadhar Kinal, my teacher, and Dr. Madhuri Gore is present here today. And she's a very well-known teacher of the whole country, and we all look up to her for so many things, and we all admire her, and she's a lot of inspiration to us. If Madhuri ma'am could just switch on her video, we could all see her for once. Ma'am, could you?
79 years old,
Uh,
non-diabetic and hypertensive.
yes, ma'am. Thank you, ma'am, for being there. Thank you so much.
Thank you,
Welcome, ma'am.
madam.
Welcome, ma'am.
Yes. So now the topic for today is chronic granulomatous mastitis. I'll start sharing my screen. Okay. Okay. Can you see my screen?
Yes, yes, it's visible.
Okay. So the topic for today is chronic or idiopathic granulomatous mastitis. And as the word itself suggests, it is chronic as well as idiopathic, and we really do not know the cause for this particular disease. Um, Mastitis, we know, is inflammation of the breast, and most of the inflammation of the breast is lactational, that is, which comprises about 90% of the mastitis, and about 10% of them are due to the other causes, of which chronic granulomatous mastitis is one. There is such an overlap of this particular condition. As Dr. Kalaivani said, it is a rare disease, but I would say it is not so rare. It is commonly seen nowadays, and hence it needs a proper diagnosis, a proper approach, so that we can find the exact cause for this disease and try to come to a conclusion as to how to treat this particular disease. I would be discussing this condition under the following headings. Now coming to introduction, this is to define chronic granulomatous mastitis. It is a benign chronic inflammatory disease of the breast which affects women of childbearing age. And the main feature about this is this inflammation occurs without necrosis. It has a chronic course with recurrences, and it has to be differentiated between simple mastitis, tuberculosis, and inflammatory carcinoma of the breast. So this is very important because these two conditions, especially tuberculosis and inflammatory carcinoma of the breast, mimic this condition so much that if you misdiagnose, then you would have that would lead to a catastrophe. This was first described by Kessler and Volok in 1972, and in spite of 50 years from then, we still are not sure about what is the cause for this disease and what is the and how we treat this particular condition. The incidence is about 2.4 per lakh population. It is common in Hispanic, Asian, and Arabian populations. It usually occurs 2 years after lactation, and the mean age is about 30 years. There have been 2 cases in men reported and a few cases in pregnancy. Now, to understand mastitis better, we'll try to classify it into these 3 categories, that is infectious, non-infectious, and malignant. In infectious, we have simple mastitis, that is lactational and non-lactational, complicated mastitis where there's an abscess, draining sinus tracts, infected cysts, infected galactoseals, infected post-interventional collections, and in specific mastitis, that is tuberculosis and fungal. In non-infectious, we have periductal mastitis and duct ectasia, plasma cell mastitis, granulomatous mastitis, diabetic mastopathy, post-irradiation, and secondary mastitis, which could be due to vascular diseases, collagen disorders, post-traumatic fat necrosis, and foreign bodies. And in malignancy, we have inflammatory carcinoma of the breast and abscess in a malignant lesion. Now, coming to etiology, we all know that the exact cause is not known. There have been 3 hypotheses that have been put forth. One is autoimmune, 2 chemical, and 3rd is infectious, and mostly occurs as an autoimmune response to an epithelial damage. And the agents responsible are local irritants, viruses, mycotic infections, parasitic infections, diabetes, smoking, chemically induced, probably due to response to oral contraceptive pills. Prolactin is found to be raised in most of these patients. A prolactin is supposed to have a pro-inflammatory and a stimulatory effect. Bacterial invasion may be a factor, especially Corynebacterium cropensetae. This has been cultured in many of these patients. Presence of Corynebacterium cropensetae is not determined in all because this is a slow growing organism and it is difficult to culture. Some authors try to put this in a separate group called as cystic neutrophilic granulomatous mastitis. There is also a condition called alpha-1 antitrypsin deficiency, which leads to paniculitis. And whether this chronic granulomatous mastitis is a part of paniculitis is yet to be confirmed. Now, the pathogenesis of the disease. This disease occurs in lobules, and hence it is called as idiopathic lobular mastitis. And the inflammation occurs without necrosis. Luminal secretions and lactational secretions are extravasated into the stroma. This occurs due to epithelial damage following trauma, infections, and this disease this causes in local inflammatory response leading to chronic granulomatous and granuloma formation leading to chronic granulomatous mastitis. This type of inflammation occurs in many of the diseases, and they have been put into into a same spectrum, that is duct ectasia and periductal mastitis. And these have been conceptually grouped into a body of entities referred to as mammary duct associated inflammatory disease sequence. So these are probably belonging to the same disease. Now coming to the presentation, most of them present with a painful mass, erythema and swelling which are signs of inflammation are commonly seen, congestion of the breast, nipple and areolar retraction, fistula and sinus tracts are common, abscess may be present, lymphadenopathy is seen in about 15 to 50% of the patients, and in some of them it may mimic cancer due to the presence of skin and nipple retraction. Any questions till now, or should I go ahead, sir?
Yeah, we'll take questions, no? Anybody?
There are no questions in the chat, but any of the PGs have any questions, or anyone for that matter? Any delegates have any questions? PGs?
Can I
Yes,
just?
sir. Yes, sir. Please, sir.
Yeah, Dr. Naz, that's can you just go to slide number 3, that classification?
Yes, sir.
Just for the just for the sake of postgraduates, I see the 1 or 2 small clarifications here, because in the malignant group, generally we teach them lactational and non-lactational. There's also 5 infectious and non-infectious. Inflammatory carcinoma per se is mimicking a inflammation rather than a real abscess. What happens is these postgraduates will ultimately.
Your connection is poor, sir. Your audio is not clear.
Can you hear now? Can you hear now?
Yes,
No,
yes, yes, yes. Now it's clear.
You can hear, sir? Shivram, sir?
Yeah.
Hello? So, Shivram, sir, can you hear?
We can hear. Go on,
Hello?
Dr. Rajgopal Shane.
Nothing. I just wanted only one postgraduate to read it little carefully, in the sense there is no sound from my side. I think somewhere else, I think the.
Correct. You can carry on.
Yeah, nothing. I just want PGs to be a little careful when you say inflammatory carcinoma. There is not abscess there. It is the signs mimic like a inflammation. So wrongly mistaken an abscess and incision is given very often. The tumor fungates. I just wanted PGs to understand this. That's all.
Shall I go ahead, sir?
Any specific feature where we can suspect this condition clinically?
So we'll come to the clinical features further. But one thing is, this disease is a disease of, you make a diagnosis of the disease by exclusion. You don't have particular signs and symptoms to say that this is chronic granulomatous mastitis. You have to keep this in your mind in a differential diagnosis, rule out the other conditions, and then come to a conclusion that this is chronic granulomatous mastitis. Histopathological confirmation is a must in all the cases. We cannot just think it is chronic granulomatous mastitis and treat it this way.
Dr. Naz.
Yes, sir.
So just correct me if I am wrong. What we used to classify as the chronic granulomatous mastitis into one is idiopathic one,
Yes, sir.
where there is no etiology is known at all.
Yes, sir.
The other one is the secondary one, where you gave a lot of reasons like sarcoidosis or tuberculosis, and sometimes the drug induced, all these things. So is that the correct way to classify the chronic granulomatous mastitis, idiopathic and secondary?
I didn't come across this kind of a classification, sir. But then we have to rule out these conditions. Yes, sir. So we have this one condition, that is idiopathic cystic neutrophilic granulomatous mastitis, and that is probably supposed to be due to Corynebacterium. The others, we have to rule out other conditions.
Right.
Okay.
Dr. Rajgopal Shanai, you have anything to say?
Can I just ask one question? Dr.
Sure.
Naran Hepsur here, sir.
Hepsur, welcome.
Thank you, sir. Is malignant abscess word can be used, or do you think it is relevant?
I wouldn't say that way, but it is sometimes what happens due to intervention or something, an abscess may form, and that is why you should keep it in mind. That's all. So malignant abscess is, in a malignancy, there is an abscess which is formed.
Yeah, that is the area of a little bit postgraduate should be a little careful about that last column. That's what I also made a comment on that. Both the inflammatory carcinoma and malignant abscess per se.
They cannot give a diagnosis as malignant abscess.
I don't think so. This term can be used, no, sir. Don't you think so, sir?
That's what I said. But there is she has given the classification from a book, I think, that quote she has given. I saw that.
Yes, sir. Yes, sir. I saw that.
Reference has been given, but I already made a mention that postgraduates, I think, to be a little careful about that. So both that last column. What Shivaram told is also right, madam, that granulomatous idiopathic, as the name, you already clarified that due to the cause is not very clear. Other ones are the ones which you have given the list here.
Yes, sir.
Big, so many things can cause.
Yes. Shall I move ahead, sir?
Dr. Kalevani, there is some question in the chat box. Kalevani is not audible. Okay. I will only ask. Can breast abscess post-IND lead to granulomatous mastitis? Dr. Narayan Kabadi is asking.
Breast abscess may, chronic granulomatous mastitis may present as an abscess. There may be an underlying disease already. It may present, and later on we might diagnose it as a chronic granulomatous mastitis. It is not vice versa.
Correct. Many times granulomatous mastitis presents as a breast abscess, and when you drain it, it may not heal at all, and then finally you do a biopsy or something, you may diagnose the granulomatous mastitis. That's correct?
Yes.
Yeah.
Shall I proceed, sir? Yeah.
Oh, Kalevani, please.
Okay. Yes, sir. Yes. Sorry for that interruption. Please proceed, Dr. Nas.
So now I've completed this slide pathogenesis. And
yeah.
Presentation. Most of these patients present. I think we have finished this slide also. Moving on to the next slide. Now there are 4 distinct patterns we can broadly classify this into. Patients present with a firm and hard painful mass in more than 52.9% patient, localized inflammation or an abscess in 26.4%, a mass with sinus or ulceration in 7.5%, and a hard painless mass that mimics cancer in about 13% of the patients. And there has been a proposal for a clinically based classification for idiopathic granulomatous mastitis, so that we can divide these into, we can stratify our treatment based on this. So this is a localized mass which is formed. This is a hard mass, and these are multiple sinuses. And the other one is the ulcer, which is ulcer and sinuses which are formed. So based on this, you can decide your treatment. Now coming to investigations, again, this is a disease of exclusion, the diagnosis based on exclusion. We do not have a particular way to diagnose chronic granulomatous mastitis. Routine investigations are done, like a complete blood count, which will show you a raised leukocyte count, especially when there is an abscess or an inflammation. ESR is raised, especially in tuberculosis. Diabetes is also a coexisting in many of the patients. CRP may be raised usually up to 1 to 1.5 milligrams per deciliter. Serum prolactin levels, it has been found that this is particularly raised in most of the conditions, and hence this has been proposed as one of the causative factors, and a tuberculin test to rule out tuberculosis. On imaging, you use ultrasound as the first line to come to a conclusion that some kind of inflammation is present. A mammography is also done. MRI especially helps in ruling out malignancy if there is a coexisting malignancy, or if there is a confusion that this could be a malignancy, and a chest X-ray to rule out there is pulmonary tuberculosis. FNAC, core needle biopsy, and incision and excision biopsy, or a vacuum assisted biopsy, these are also done. I'll be coming to it in the coming slides. Most important is once you aspirate the pus, if it is present, it has to be cultured, it has to be stained. Stained for as well tuberculosis, a pus stain is also done, and for fungus, a GMS stain is done to rule out whether the organisms are present. A TB PCR or a CB-NAT and a mycobacterium culture is important to rule out tuberculosis. And a special culture is done for Corynebacterium because these bacteria are slow growing and they are difficult to culture. Hence, care must be taken to culture these organisms. And to determine autoimmunity, there are no specific tests. Rheumatoid factor, ANCA and C-ANCA, and anti-double strength DNA antibodies are done to rule out lupus. Now coming to ultrasound, on ultrasound we find multiple contiguous hypoechoic masses with posterior acoustic enhancement, acoustic shadowing or enhancement. In advanced cases, there may be fluid collections and cavities in association with skin thickening, sinus and fistulae formation, sinus formation. And most cases present with hypervascularity, which can be detected by Doppler imaging. And there may be multiple small masses in some patients, and 15 to 55% of the patients show ipsilaterally enlarged axillary lymph nodes. Ultrasound is also helpful in determining the response to treatment, and you can follow up these patients and store the images and see if these patients are responding to their treatment. Now, mammography shows a large focal asymmetric density with no distinct margins and mostly identified when compared with the contralateral breast. It is mainly unilateral and most often seen in the periphery of the breast. Usually an irregular, ill-defined mass is seen. Sometimes multiple small masses are also seen. There may be a lobulated large irregular mass or a diffuse increased density of the affected breast. And hence, since it gives a comparison with the opposite breast, a proper diagnosis can be made. And overlying skin thickening is also important. And these patients can also be followed up with using this image. On an MRI, there are ill-defined masses and non-mass enhancement depending on the severity of the inflammation. On T2, they are hyper-intense and peripherally enhancing masses with central areas of enhancement representing abscess formation, and that is typical of advanced diseases. All of them show intense enhancement. It also gives a comparison with the rest of the breast and with the adjacent and with the opposite breast. And axillary lymphadenopathy, skin retraction, nipple retraction, skin thickening, and sinus tracts and parenchymal distortion are all appreciated on an MRI. Now, coming for fine needle aspiration versus core needle biopsy, the gold standard for diagnosing granulomatous mastitis is core needle biopsy of the lesion with a sensitivity of 96%. And the low sensitivity of fine needle aspiration, that is 21%, is because of insufficient material and non-specific findings, that is fat necrosis and an abscess. Incision biopsy may be required in some patients, and some patients may even require an excision biopsy. And as far as possible, an incision on these lesions must be avoided because it leads to extensive scarring and sinus formations, and they may not heal for quite some time. And curating of the, if at all you have done an incision and drainage, the wall should be curated, and these should be sent for culture, CB-NAT and TB PCR, and for histopathological examination as well. And a vacuum aspiration assisted biopsy also gives a good tissue sample. Anything till now, sir? Any questions?
I think any question, there are no questions in the chat box. However, any other delegates have any questions to ask at this point of time? Okay, I would like to ask on behalf of the students present over here. So, Dr. Naz, since so many investigations were mentioned, what will be the investigation of choice when the PG is asked a question? What's the investigation of choice? What will they suppose? What will they say as first one?
See, you will be doing all the routine investigations. The main thing is you do an FNAC. If there is an abscess, you try to aspirate it and send it for culture. And otherwise, you do a true cut biopsy, and then you do the required test as I mentioned in the previous slide.
Okay. I think based on this, whatever, I think for the postgraduate, I mean, for you to identify an ultrasound of the breast will be the first investigation to understand what exactly the pathology is going on, because it fairly gives a better diagnosis in an ultrasound rather than mammography and other findings. Mammography probably will be indicated when malignancy is suspected. And cord biopsy, as you said, will be the pathological investigation. Regarding other investigations, sir, Dr. Shenoy, sir, would you like to comment?
No,
This NAT test is performed for all abscesses aspirated, is it? Or any specific characteristic of first that indicate that NAT test to be done? Because most of the breast abscesses drain, we don't do the NAT test, no?
No,
So this is, please go ahead, Dr. Nas.
Usually these patients don't come up with only a single abscess. For the first time, you do not think of a chronic granulomatous mastitis.
Yeah, that's why.
Coming with a recurrent presentation, and then there's a suspicion that this is something beyond a simple mastitis. Then you start thinking in these lines, and once you do these, you do an ultrasound, you find that there is a mass. You look at the wall. Then there are sinuses, there are fistulae. These are the conditions where you start thinking that this is not a simple mastitis, and that is where you do all these investigations. Not in every case of simple mastitis you try to do these tests.
Yeah, I would like to add only one or two small points that autoimmune already mentioned in the etiology, but so look for the autoimmune evidences in a female patient, because most of them are in this 30, 40 years of age. So evidence of joint pain or even a salivary gland enlargement, these are all indirect evidences of an autoimmune disease. Per se, more common in women and or without spleen. So this is just in the examination, in the clinical examination, keep it in mind if you suspect a autoimmune disease.
And erythema nodosum also, sir. So they have to.
Yes.
PGs should mention about that. So, any other questions? Yes, sir. Please, sir. Yes, sir.
No, as Dr. Naz has put in nicely, what evaluation has to be done is decided by what presentation patient has. So if there is a lump, then definitely you have to do imaging and then the true cut biopsy. And if there is an abscess, you have to aspirate and then send it for the culture sensitivity, FNAB, the AFB staining, everything. I think FNAC has not much of a role in these cases because, as you have yourself has put it, the yield is very low and sensitivity is very less. The best investigation, if there is a lump in these cases, is the true cut biopsy after doing a proper imaging. That will give most of the time. But if you have done an already in a drainage and there are sinuses, there are abscess, then the evaluation may differ. So I think the best way to go ahead is what is the presentation of the patient. Accordingly, we have to evaluate instead of running through the patient all the tests or anything.
Can I make a comment?
Dr. Bharti, ma'am, please.
Naz has given a very good list of investigations, but I think amongst imaging, mammography is rather a painful procedure, particularly when patient is coming with pain or has abscesses, as there is pressure exerted between the plates. it becomes pretty painful investigation for the patient. And as far as the image quality and differentiation between pathologies is concerned, probably MRI is the best investigation, though it also happens to be the most expensive investigation. But that can certainly differentiate, especially between malignancy and non-malignant situations like granulomatous mastitis.
True, ma'am. Thank you. Thank you for that information. Dr. Bharti, ma'am, you have any comment?
Yeah,
think,
I would like to say, I see quite a few of these, and most of them present, as Dr. Naz has said, with periductal pictures of recurrent and chronic abscesses. But recently I saw a very interesting case of a 41-year-old lady. She came with enlarged bilateral breasts since the last 3 to 4 months. And when she presented to us, she had a alarming picture of almost like a inflammatory carcinoma of both breasts. So she had large breasts and inflammatory carcinoma of like picture of the whole, all the breast and the chest wall. So this was very alarming, and I was wondering what I was dealing with. Then I put her on antibiotics, anti-inflammatory. For a week, when she showed signs of improvement, I continued it for another week. Following that, because of the large size, the only investigation, other than ultrasound, was MRI. And MRI surprisingly didn't show anything within the breast, but it shows thickening of the skin, which was looking like pudy orange. This had settled around 50% and not come to normal. So now with this picture, I couldn't do a true cut. I mean, I thought that true cut is not going to give me any answer. So I did actually from both the medial quadrants close to the nipple areola, because I didn't want to miss a periductal mastitis, etc., though it didn't show in the MRI. I did excision biopsies, and surprisingly, both of them came as from both the breasts came as granulomatous mastitis. So this was a slightly different picture where the skin only was involved. There was nothing inside. So core needle was ruled out. I actually did small excision biopsies, and she subsequently, over the few months, the breasts further enlarged to 2 to 3 times, and she came with huge, gigantic breasts. Then later on, she also was diagnosed as psoriasis. So this was some autoimmune process going on in her, but a very interesting and very different kind of picture for her.
Thank you, ma'am. Thank you for that input.
And also, I feel like somebody asked a question that if you have an abscess, should you drain? Yes, you should drain, but if you get an abscess in a non-lactating woman, I think you must keep in mind periductal mastitis, chronic granulomatous mastitis. It may not be chronic, it may be your first episode. These have to be kept in mind, I think, if the patient is non-lactating. These are what I would like to say.
Thank you, ma'am. Shivaram, sir.
Sorry, Bharti madam.
Dr. Madhuri had some comments, I think.
Yeah.
Ma'am, Dr. Madhuri, ma'am. No, sir. Madam finished speaking, sir. So,
I'm Dr. Epsur here.
Dr. Narayan, please. Please go ahead.
I want to ask a question to Bharti madam. Madam, how did you manage that patient then? What was your further management after psoriasis diagnosis?
Then, So she was put on treatment for her psoriasis, and I put her on a course of steroids. That steroids cleared the skin completely. But her prolactin, everything was normal. Her hormonal assay, everything I got done with the endocrinologist, everything was normal. But this huge gigantism with skin involvement is known in autoimmune, rarely, very rarely. So I have now, it has stabilized. I've advised her reduction mammoplasty, because she comes with 2-3 towels tightly, and she can't, when she opens it, she can't sit because the breasts are so heavy. She can't lie down. It has to be always tied. So her condition is very miserable. And the only diagnosis out of everything, where the MRI and the biopsy, was chronic granulomatous mastitis. That was the only diagnosis we could pick up.
Okay, ma'am. Thank you.
Thank you, ma'am. Thank you. Any other questions? Okay. Shall we proceed, Dr. Naz?
Now
So
coming to differential diagnosis, we have a huge list of differential diagnosis in these patients because the exact cause of this particular disease is not known, and we believe it is autoimmune. And just like Dr. Bharti ma'am said that it was associated with psoriasis. So there are a number of conditions which could cause this similar picture. One is tuberculosis mastitis. The most important thing is we have to differentiate chronic granulomatous mastitis from tuberculosis as well as carcinoma breast, because we at some time in the course of treatment we initiate the treatment with steroids, and if we miss tuberculosis, then the patient may land up with fulminant tuberculosis. And if it is a carcinoma breast which we have missed, the patient, we would have missed the bus and the patient would have moved to a further stage. So it is important that we differentiate these two diseases. And then there are other autoimmune diseases, many other diseases, like we have plasma cell mastitis, and here, which are all mainly based on histopathological confirmation, and that is the non-granulomatous, vaginous granulomatous mastitis, granulomatosis, that is associated with vasculitis. A ruptured cyst can cause a similar picture, but this is non-lobular. It doesn't localize to one particular lobule. And then fat necrosis, where there are foamy macrophages, and again it is non-lobular. A duct ectasia, where there is periductal fibrosis. A diabetic mastopathy mimics this condition. Usually diabetic mastopathy is seen in type 1 diabetes, and it is associated with extensive fibrosis wherein the lobules are trapped and there is hyalinization. Fungal infections can be determined by GMS stains. Sarcoidosis mimics this condition, and usually there are naked granulomas in this, and that is they lack lymphocytes, and then lacking lymphocytes. Foreign body reaction, where there is a polarizable material seen, and IG4 related disease, where there is fibrosis, lymphocytes, as well as vasculitis. So there are so many other conditions which mimic chronic granulomatous mastitis, and they all can be confirmed most of the times by histopathology and immunohistochemistry.
Dr. Naz has given a very elaborate differential diagnosis. Any questions from the audience, please? And she has beautifully explained how each one is differentiated from granulomatous mastitis. Dr. Naz, if you can just tell them the point to differentiate between tuberculosis and granulomatous mastitis, which is the most common differential diagnosis.
The differentiation in the next slide, I'll show it in the next slide.
Okay.
And here I just wanted to put up this picture because you can see the overlap of granulomatous mastitis with so many other conditions. So that is why it is quite difficult to diagnose, and a high index of suspicion is always necessary when the patient presents with non-lactational mastitis. So we are talking about non-lactational mastitis, and that is why as much as possible avoid an incision drainage in a patient who has presented with non-lactational mastitis, because most of them will land up with sinuses and fistula formation and extensive scarring, and they are multiple. So that is why you should avoid incision and drainage. Because I wanted to add this point, because whenever the patient presents with an abscess, we have a tendency to put a knife. As much as possible nowadays, we try to drain even larger abscesses with the repeated ultrasound guided aspirations. That is a better method to follow, and we can treat most of the abscess by aspirations, repeated aspirations. So this is
yeah. Thank you, Dr. Naz. There is a question in the chat box. This is from Dr. Narayan. Is pregnancy adenosis a type of granulomatous mastitis? Is a question.
I am not really aware of this.
Even in the differential diagnosis, even in pathology, we did not come across this. So, Dr. Narayan, hope we have explained this. Yeah. It is not mentioned in the literature, at least.
I have not.
Okay. Yes. So basically, the difference between tuberculosis and granulomatous mastitis is based on the histology. There is more fibrosis in tuberculosis and more plasma cells in the granulomatous mastitis.
Here put up this slide to show that these are the three conditions which we have to be very sure before starting treatment for granulomatous mastitis, because the treatment duration is long, and then we would have the treatment line is totally different. So as Kalaivani said, there is extensive fibrosis. Tuberculosis presents at a younger age group. There are masses are much larger, and there are multiple sinuses and fibrosis. And these patients, so now coming to all the three, mass is present in all the three. And coming to the location of the lesion, in tuberculosis, it can affect any part of the breast, so also carcinoma of the breast, but whereas granulomatous mastitis is mainly peripheral, that is it because it is lobular. And then overlying skin is involved in all the three. Nipple retraction is also seen in all the three. Sinuses may be present in tuberculosis and granulomatous mastitis, whereas absent in carcinoma of breast. And axillary lymph nodes may be are enlarged in all the three. And fixity to the underlying muscle can also occur. And now coming to the histopathology, that is the main differentiating feature, where there are epithelial histiocytes in both tuberculosis as well as granulomatous mastitis, but they are more in granulomatous mastitis. There are typical Langerhans giant cells in tuberculosis, and then there are granulomas, and there are caseous necrosis in tuberculosis. There is extensive fibrosis, that's why I underlined it, and you may find tuberculosis bacilli. And if you can do a CBNAT, or you can do a TB-PCR or a gene expert, you can find out the causative organism. And whereas in granulomatous mastitis, there are epithelial histiocytes, as I mentioned, multinuclear giant cells, and there is a predominantly neutrophilic background, and there is absence of necrosis. This is one of the important features in granulomatous mastitis. And in malignancy, of course, there are neoplastic features. If anybody wants to add anything here, I think they can clarify anything if it is necessary here. Yes, sir?
Sir,
Yeah,
anyone?
I just want to bring only one thing here. In the usual practice of whatever tuberculosis, granulomatous mastitis, and I would like to compare with the periductal mastitis rather than a carcinoma of the breast. When a patient comes with because most of these patients are younger patients relatively. When I say younger, means 30 to 40 years of age. Yes, definitely it's a matter of concern when a lady comes with a lump and with some pain or something, whether it is a carcinoma of the breast. Nipple retraction, yes, we have seen that carcinomas, usually it produces directly a slit-like type of a retraction in usual this tuberculosis as well as granulomatous mastitis. So that is the difference between the retraction of the nipple. That is one thing. Presence of the sinuses, the sinuses sometimes with a lesser mass, rather a small lump, but multiple sinus. This is what happens in a tuberculosis as well as granulomatous mastitis. Whereas in a carcinoma of the breast, it is a larger lump with a smaller skin infiltration. So if I want to differentiate, I will give more importance to tuberculosis, granulomatous mastitis, and periductal mastitis. Periductal is a little elderly, and usually a disease in the duct. Then spreading.
And it is periarea.
Yeah. So it is the one also which gives rise to discharge from the nipple, but with the creamy type of a discharge. And it can give rise to a lump. It can give rise to some kind of a sinuses and axillary nodes, retraction, everything. So this is just my comments. That's all.
It's very, very, very important and useful input, sir. That was, and especially the skin involvement, which is lesser in malignancy when compared to the inflammatory. That was a very important differentiating point for PGs to make a diagnosis. Sir, Dr. Shivaram, sir, any comments from you?
So, Dr. Naz, if you say there is absence of necrosis, then what is the reason for abscess, pus formation?
So that is the Corynebacterium corpensetta is the causative organism present, sir. Sometimes other skin organisms also may be present. So that is why these patients with this Corynebacterium K, they have been identified as a separate group, that is cystic granulomatous, neutrophilic granulomatous mastitis.
Will will it be picked up with a routine pus culture sensitivity, or some special stain has to be done?
The routine pus cultures, these may not be picked up. That's why most of the time these are missed out. So they take a longer time to grow and they need fresh.
Yeah, I think in this here, I would like to add that you need a separate anaerobic culture, Shivaram. Invariably, what happens is we generally send culture sensitivity, and invariably that anaerobic thing is missed there.
If you suspect strongly, we should send for anaerobic culture also.
Anaerobic specifically we need to mention, and including fungal culture.
Fungal.
She has mentioned somewhere in the suspected cases.
Yes, in the investigations. Yes, sir. Yes.
I have seen
Dr.
that.
Naga. Yes, very elaborately she's explained. Any other comments or questions from the audience? Okay, shall we move on to the treatment, Dr. Naz?
Yes, yes. Okay. Now coming to the treatment, generally when a patient presents with an abscess or inflammatory lesion, we usually give them analgesics and anti-inflammatory drugs, and then add antibiotics. Most of the times we give them common antibiotic. Initial presentation, I'm saying, when there is no clear-cut picture, we give them common antibiotics which act on the skin flora. And these are the common organisms which cause an abscess in the breast. Sometimes when they do not respond, we switch on to doxycycline, tetracycline, clarithromycin, and clindamycin. As much as possible, incision drainage, pus has to be aspirated and sent for culture, and whatever investigations we have mentioned earlier. And the pus has to be, we have to do an avoid an incision drainage as much as possible for the reasons mentioned earlier, and for the obvious reasons. And surgery is also needed in some patients, that is in the form of a wide local excision or a mastectomy. But since, as far as possible, a conservative treatment has to be followed, and as excisions are to be done only in a very, very few cases. So this we should understand is most of the time self-limiting or can respond to our treatment, and a knife on the breast in a patient with chronic granulomatous mastitis must be avoided to the maximum. And coming to this type of surgeries, we'll come back again. And then the steroids treatment is showing promising results in the form of either systemic, topical, and even local injections, which we'll be discussing in the next further slides. Now coming to antibiotics. Now the choice of antibiotics. See, how do we choose antibiotics in these patients? Corynebacterium has been shown to be the causative organism, at least in a set of patients with chronic granulomatous mastitis, and these bacteria survive in lipid vacuoles, and they are surrounded by neutrophils. So our antibacterials, which are highly lipophilic, must be used. And beta-lactams and fluoroquinolones have a low lipid solubility, and therefore they do not act here. Clarithromycin, clindamycin, trimethoprim, sulfamethoxazole, and rifampicin have a high lipid solubility, and they are better. And short courses like 2 weeks and 3 weeks, they do not help here. So minimum duration should be at least about 3 months, sometimes even up to 6 months, especially when you're including rifampicin. Now coming to steroids, the role of steroids was shown in 1980 by Hertog et al. And he gave a dose of 30 milligrams per day for a duration of 2 months. There were a lot of side effects, and also there was a relapse. Freeman et al. Proposed a lower dose regimen of 16 milligram prednisolone twice a day for 2 weeks, and then slowly tapered over 2 months. But there was a high recurrence. A high dose therapy with prednisolone up to 1 milligram per kg per day has been proposed, and then tapered slowly. Topical steroid application, that is 0.5% hydrocortisone butyrate cream twice a day on alternate days, has been used, and it also has given good results. It must be given for a minimum of 8 weeks and a maximum of 6 months. Then methotrexate and azathioprine, which are immunomodulators, can be given alone or with steroids. They are given mainly for patients who have failed corticosteroid therapy. They help in reducing the steroid dose, and they can be continued in a low dose to prevent relapse. And a local steroid injection, which we'll be discussing later, has also been given promising results. Now coming to local steroid injection, before that, the role of steroids especially is before considering excision, wide local excision, a steroid must be given because it reduces the size of the lesion and hence the extent of the lesion to be removed will be less, so that you can remove a less amount of breast tissue. And it also has to be given after the treatment, after excision, to prevent a relapse. So this use of surgery does not prevent the use of steroids. It has to be used along with the surgery. Steroids have to be given along with surgery. Now coming to local steroid injections, there have been trials going on. There is a trial with the US NIH, that is 5 milligram betamethasone sodium or 2 milligram betamethasone phosphate injection into the breast once a week for 1 to 4 times, and then with the steroid ointment 0.1% topical hydrocortisone butyrate used twice daily versus only steroid treatment, and they have found better results with those who have received the injections. And local injection of triamcinolone 40 milligrams per ml, 80 to 160 milligrams have been also given, and they have been given under ultrasound guidance and repeated every 1 to 2 weeks till resolution. And then we came across use of methylprednisolone in one of the webinars, but I have not found any reference for this methylprednisolone 100 milligram injections. But then they have said that the papers will be coming out soon, but I did not find any reference for this. Now, the commonly followed regimen is, see, we do not give steroid in all the patients. Not every patient with chronic granulomatous mastitis has to, the treatment has to be tailored. We do not give the same treatment to all. We start with the minimum and then we start adding on. And we should avoid steroids till the culture for tuberculosis comes. Not just staining or CBNAT or whatever it is, wait for at least 4 to 6 weeks till the report of tuberculosis culture comes. Unless until then, we should not start them on steroids. Now coming to this, 40 to 60 milligrams per day prednisolone is given for 1 month, then 30 milligrams per day for 2 to 3 months, then alternate day the same dose for 2 to 3 months, and then reduce it to half, that is 10 to 15 milligrams on alternate day for 6 months, and then reduce it further again to 5 to 7.5 milligram and maintain on alternate day maintenance for 1 to 1.5 years. So that is the duration of treatment some patients may require. And if there is a relapse, the dose is increased to 40 milligrams per day. And azathioprine 2 milligrams per kg per day acts as a steroid sparing agent, and it can. And there, here we have steroid that is prednisolone with azathioprine, and there we can reduce the dose from daily dose here. Initially, the same dose is given along with the azathioprine, and then you reduce it to every alternate day. You were giving it daily here, you have reduced it to every alternate day, and that is how you come to taper. You can taper steroids early with the dose of using azathioprine.
Yeah, there are a lot of questions in the chat box, Dr. Naz.
Yes.
I'll go one after the other. The first question was, the first comment from Dr. Shenoy is a very good point on the treatment of abscesses, ultrasound guided aspiration.
Yes.
Okay. Then from Dr. Narayan, there is a question, Narayan Hepsur, a role of subcutaneous mastectomy. Is there a role for subcutaneous mastectomy?
Here, the skin, overlying skin is involved. See, as far as possible, avoid mastectomies. And when you are planning a mastectomy in these patients, the breast, that means the breast is totally involved. And in the overlying skin also would be unhealthy because this is an inflammatory disorder. And I have not come across anywhere saying that a subcutaneous mastectomy would help in these patients.
Yeah,
that's what you mean, I feel. Skin sparing mastectomy, isn't it?
Okay. What you put out the right point. It involves the skin, so there is this question does not arise. Okay. Then there's another question from Dr. Vidyadhar Kinal. Steroids to be continued for how many days? So I think Dr. Naz has very clearly explained. Would you like to reiterate, Dr. Naz?
Yeah. See, each case has to be individualized depending on the response. So you try to taper depending on, it is not a same treatment for every patient. Every patient has to be, the treatment has to be tailored accordingly. So once you start the steroids and the patient is responding well, you can taper it little early, and then you keep them on a maintenance dose. And once you stop, if there is a relapse, you start again, then you keep them on a maintenance dose again.
Okay, thank you.
1.5 years a maintenance dose has to be given in those patients who are very resistant to treatment.
Dr. Shivram has a comment here. Side effects of steroids to be explained to the patients.
Yes, we have to. See, there is a that is the main thing with the steroids. And once you stop the steroids, the disease might recur. That is one thing you have to explain to them. And then the side effect, that is, they put on weight. There could be hypertension, hyperglycemia, and these are the things. Then they could have excessive hair growth and all that. So these patients
But intralesional steroid, does it produce so much side effects?
Yes. I didn't get you.
Intralesional steroids. Will intralesional steroids produce any side effects is his question.
The dose of steroid, see that it could have some amount of systemic effect, but then the overall treatment is not prolonged for so many days.
No,
So
it is all intralesional. There is probably...
No, Srikanth. Main therapy is oral
Oral.
corticosteroids, prednisolone. So they'll be immunosuppressant and
oral is the main, is it? Okay.
oral
Yes,
therapy.
sir.
See,
Okay.
if you don't explain to them, they will stop after 1 month or 1.5 months. They come back with a again
systemic
recurrence,
side
then
effects.
again you have to start. So it's very, very important to explain to them the side effects of steroids. Some of them develop diabetes in between, and the treatment may go on for a longer time, and their face changes, they put on weight. All these things has to be explained. Also, we have to monitor the blood sugar and also the WBC count, all these things. So it's important monitoring of these patients when they are on corticosteroids also.
and possibility of secondary infections, yes.
Yes.
I have some experience with the few of at least some 15 to 20 of these patients over many years. First, as rightly put it, individualize the treatment. That is the first thing. What we are talking mainly, this discussion on steroids, methotrexate and all, definitely is referring to that idiopathic granulomatous mastitis, which is most probably an autoimmune etiology. That is what we would like to think. Like any other autoimmune disease, whether it's this is a problem, is a recurring problem. It doesn't respond. Sometimes it responds within 2-3 months, and we find that patient is all right. Then they will come back after some time with little more problems. Again, compliance with the steroid is also a problem, as Dr. Shivaram has put it. Complications, then tolerance, then so many things will happen in between. Sometimes they come with a small palpable lump again and again. So what important thing is, just because there is a lump or something, as long as you have a diagnosis which is made, you are ruled out a malignancy, reassurance is the important thing in this type of patients. Because very often, this is a self-limiting disease many times. But some of the pictures, whatever Dr. Naz has put, of course, they are really scary with such big lumps.
No, I showed the first picture, which was very small, sir.
No, I'm not telling that. No, it happens. As Dr. Bharati Madam also mentioned a case of this with a very big lump. So basically, it's a long remissions. We need to be ready with the treatment for a long period of time. Reassurance, self-limiting. These are some of the important points in addition to antibiotics and all that, whatever you have told. I have no experience of treating with the methotrexate, but prednisolone I have treated, and diabetic status is one of the things which we need to check. That's all my comments.
Patient
Thank you, sir.
cooperation is very much required.
Yes, sir. Naz, there's one more comment. Immunosuppression. Probably sir is asking, what is the role of immunosuppression? This is from Dr. Vidyadhar Kinal.
Only in those resistant cases, especially if you have tried all the treatment, you can use these. You are using steroids, and these immunomodulators, that methotrexate and azathioprine, can be used to taper the steroids early, and they can be used as a maintenance treatment, because these are autoimmune diseases. And you use methotrexate, and you use these drugs for rheumatoid arthritis, so you can use this for similar conditions.
Thank you, Dr. Naz. There's another question in the chat box. Using, this is from Dr. Natraj, using of immunomodulator, is there a need for involving the physician or an immunologist in the due course of treatment?
See, this is the treatment for the chronic granulomatous mastitis is by a multidisciplinary approach. You have a radiologist with you. You should, whenever you start steroid, you must take a physician into your team, and then you start them with prednisolone, and with, of course, with immunomodulators. It has to be. It has to be. Because I do not have a personal experience using methotrexate and azathioprine personally. Whenever I have to start these drugs, I usually take a physician's help.
Always better, correct.
What is the role of doxycycline, Dr. Naz?
See, doxycycline is started in the initial part, in the initial phase. See, first you start with routine antibiotics, what you're using for skin flora, like you use amoxiclav. These are the antibiotics which you generally linezolate. These are the antibiotics you choose when the patient is present with a simple mastitis or a simple abscess. Once the patient has not responded, by then you would have sent for a culture and you're waiting for a culture report. You switch on to doxycycline. And if they're responding, you do not stop them immediately, like for 10 days or 15 days. Continue it for at least 4 to 6 weeks. And then if there is a remission, that is it. If there is no remission, meanwhile, you're looking for Corynebacterium and these are the things, and maybe you will start them with clarithromycin. And by then, maybe have come to a conclusion that this is chronic granulomatous mastitis and you have confirmed that this is not tuberculosis and there is no malignancy. By then you start them on steroids. That is how you go about it.
Yeah. My personal experience with doxycycline is, even after getting a confirmation of chronic granulomatous mastitis, somehow I was very skeptical on steroids. So I had put them on a trial of doxycycline in quite a few patients. And actually, they all recovered. But I gave them for about 4 to 6 weeks with a routine follow-up with blood investigation, especially the neutrophil count. And they did well. This is my experience on my patients. And they haven't come back with a recurrence.
Yes.
Because I have followed them up for more than a year and 2.
So that's what
I comment.
Can I just put in a word here?
Yes, sir.
Yeah.
Dr.
Yes,
Chalani.
sir. Yes. Yes, sir. Please tell me, sir. Good evening, sir.
No, same thing I wanted to comment. It was an excellent presentation and excellent explanation about that one. Same thing I wanted to comment about doxycycline. I have given prednisolone for long period in many patients. As she told, it is an individualized treatment. And really, it is individualized treatment. Some patients, they respond, some they don't. So I discussed in detail with the pathologist and she has given me some literature. In that, it was given that doxycycline helps. So I have given minimum 3 months, extended up to 6 months. And many of my patients, I have quite a few number of patients, granulomatous mastitis. Many of the patients, they responded very well with the doxycycline, but not with the prednisolone. So that is why my personal experience with the literature, she has given me all detail and I have given, and still one more patient is there with me at present. She is also taking doxycycline, almost 3 months over. And I think we will extend and she is absolutely all right. No recurrence, no complaint, no symptoms. So I think doxycycline we can try. If you want, I can send that literature, which one was showing that one.
Please do share, sir.
Yeah. I would just like to make a point here, Dr. Bharti here.
Yes, ma'am. Please.
Yes, madam.
It all depends. The response will all depend. If there is an infection, chronic infection, then it is going to respond to the long-term doxy and clarithromycin and all those. But if it is an autoimmune, then I think steroids work better. So doxy, however long you give, if it is autoimmune etiology, it's not going to respond.
Yeah.
If it is autoimmune, then only steroids will help. Only steroids will help.
Naz was telling that it is individualized treatment. So maybe our patient might have not been much autoimmune problem or something like that. Because I have already given 3-4 review with the slides for this one, and it everybody showed that it is chronic granulomatous mastitis.
No, I would just wanted to make a point here. So that is why some of the authors try to differentiate this infective part is cystic neutrophilic granulomatous mastitis. Probably they are the ones which respond to antibiotics. So those are the ones, that is where.
So if a long-term antibiotic has not given, I think it's worthwhile trying steroids, but of course we all know steroids should not be your first line of treatment.
Yes, madam. I think full evaluation and confirmation of the autoimmune nature, all that has to be done. Then only this discussion
Yes.
of steroids and other things will.
Yes,
Otherwise,
yes.
otherwise it is like any other breast abscess, but continuing the process with infective elements. So,
like the patient I described, later on she told me about some patch of skin lesion on her thigh, and then when we examined, it was psoriasis. And then, you know, these are all associated, and for her, hence steroid work. So that's what I'm saying. The subtle differentiation in the etiology will help us further in the treatment.
I think Dr. Bharati has made a very good point. See, you have to differentiate idiopathic granulomatous mastitis from the rest of the other things. Idiopathic granulomatous mastitis, which is an autoimmune disease, responds only to immunosuppression, that is steroids or other things. See, other things can the other infections can probably will respond to doxycycline, all those things. But if you are treating idiopathic granulomatous mastitis with other antibiotics, it will be waste of tons of antibiotics. It has to be treated with corticosteroids. That's why I said first idiopathic granulomatous is different from the other types of chronic granulomatous mastitis.
There are some questions in the chat box. Dr. Naz, shall we take up that? Is minocycline has better penetration capacity than doxy? This is from Dr. No, I'm not getting the name is not available. I give for 3 months low dose. This is I don't know who. It only displays the phone name.
No,
and
yeah, it may have a better penetration capacity, but whatever we talk, it should be literature backed by the literature. So I cannot just go on saying that I treat this many patients and they are doing fine. Unless we are documenting our cases and report it, then we can have a meta-analysis on these, and then definitely it will come into the picture. Otherwise, one patient I treat with this and the patient has done fine, I cannot confirm that this particular treatment is going to be better. So that is how it is. So most of the times I find doxycycline in the literature, so I usually mention it as doxycycline.
Okay. From Dr. Madhav, is there any role of antioxidants in granulomatous mastitis?
So specifically, see, they can all be given as adjuvants as to boost your immunity, but that studies have not shown that you give antioxidants and they are going to be better. So you can give it as a supplement, that's all.
Okay, there is a comment from Dr. Vidyadhar, Dr. Khaled, and Dr. Preeti that it's an excellent presentation, Dr. Nas.
So many excellent drishti.
Any other comments from anyone else?
No, I still have some more slides to show.
Yeah, let her finish off.
Oh, is it? Okay, okay. Please, I thought it's done. Okay, sorry, please. Please
Coming
go
to
on.
methotrexate is also given like in rheumatoid arthritis, as I told. Like you give a dose of 7 to 7.5 to 25 milligrams, but then you have its side effects which have to be explained to the patient once again, like stomatitis, leukopenia, nausea, abdominal distress, all these things you have to explain to the patients, and then you can start them on these. And these are all extremes of cases which are very resistant to your treatment. So you don't start these on every patient. Again, I want to stress this point. Now coming to surgery, there are 2 surgeries. That is, one is wide local excision and mastectomy. But I have put this as inverted commas because we have to drill this into our minds that the decision at what stage of the surgery is performed depends on the individual clinical appraisal of the patient, as does the choice of surgical technique, which varies from wide local excision to mastectomy. So it is not that you do surgery for every patient. It is only you have to individualize and then do the surgery. And once again, steroids must be added before as well as after the wide local excision. And even after they have said that it has to be added even after mastectomy, because the disease can occur in the other breast also. So you have to add steroids to these patients. Now this is a flow chart. If everybody has understood, I can just skip this. But again, I can explain this again in the summary, I feel. So just to go through this quickly, a fine needle aspiration you do for a patient after radiographic evaluation, that is mammography. So as Madam Madhuri Madam said, mammography to be avoided because it is painful. So I would prefer to do an ultrasound, and then we do a fine needle aspiration. And if there is a fluid, you aspirate, do a stain, culture, and then if you find that it is culture positive, treat it accordingly. If it is culture negative and you find that it could be chronic, you are not confirmed with the diagnosis, go for a core neonatal biopsy. And along with that, you also do the culture of that, look for tuberculosis, look for malignancy, and if there is granulomatous mastitis, treat accordingly. And if there are localized findings, if it is a mild disease, treatment, and if you find that there is evidence of infection, you can go for clarithromycin for about 3 months, and sometimes you may even add rifampicin. If not, if they have not improved, you can add steroids, and if it is a disease is not really improving, you can add methotrexate or azathioprine. And at the end, as a last resort, surgery, that is wide local excision or a mastectomy, may be needed, especially in that large breast lesion which I showed. I think any other treatment would not have helped that patient in the pictures which I had shown. Then now coming to the follow-up, depends on the response. And initially you follow them every 2 weeks, and then you call them every 6 weeks and 3 months, and you look for relapse. And then coexisting malignancy may be present, and hence once you diagnose a chronic granulomatous mastitis, it is not the end of it. Patient should be evaluated regularly and treated accordingly. Now to summarize, now the disease we know has been described 50 years ago, but still we do not know the exact etiology, and therefore the treatment is mainly hypothetical. The most important factors involved have been proposed as pregnancy, lactation, and hyperprolactinemia. And Corynebacterium K, probably it has been underreported, and that therefore I request all those people who are treating chronic granulomatous mastitis to start reporting, documenting their cases, find out how many patients have this, so that you can differentiate this with cystic neutrophilic granulomatous mastitis. They respond well to clarithromycin, clindamycin, and if necessary, even rifampicin may be added, and that is for a period up to 3 to 6 months. And imaging is necessary, especially ultrasound. I would take off mammography here. It is definitely useful, but ultrasound is always better. It is cheap. It is easily available, and it is cost effective, and you can especially if you are doing the ultrasound yourself, you can monitor the progress of the disease, and you can tailor the treatment accordingly. MRI is also useful. Do not miss a chest X-ray, because it might help you to give you a clue of tuberculosis at the first instance itself. And then if there's an abscess, avoid incisions as far as possible. Since the autoimmune theory is most relevant, steroids and immunosuppressants have a role, and steroids to be given may have to be, I don't say to be given, may have to be given for 1 to 1.5 years. There may be side effects, and there could be relapses. There would be side effects. And then topical and intralesional steroids can help in reducing the systemic effect of steroids. And then they have been given alone or together, that is topical steroid with intralesional, and they have given promising results, but we have to wait for some more time. And once the results come out, maybe the treatment may be more come as protocols, and then we can start using them. And then methotrexate and azathioprine, they are steroid sparing, and they can be used in maintenance therapy as well. And most important here, I would once again add, is differentiate from tuberculosis and carcinoma, and then start the treatment for chronic granulomatous mastitis. And these are some of my references. And before I complete, much has yet to be understood about this disease to determine the treatment protocol, which is possible only by proper documentation and reporting by every treating physician. So the disease is rare, but not so rare. So unless we try to give our inputs, not much can be gained by just saying that I give this treatment and this patient has responded. So that may be only for you. Unless we share our treatment protocols, probably we will not come to a conclusion in the near future about the cause and the treatment for this particular disease. Thank you. Thank you, everyone.
You made a very, very valid point, Dr. Nas. There are some more questions in the chat. Is there a role for rifamycin?
Rifampicin can be given, especially if they don't respond. One is, see, you do a tuberculosis culture, there could be atypical mycobacteria. If they're not responding for your clarithromycin, then you can add rifampicin for a period of 6 months.
Okay. There's another comment from Dr. Khalid. If the condition is deteriorating while on immunosuppressive therapy, whether the diagnosis of granulomatous mastitis is ruled out.
Maybe you have to reevaluate this patient again. And if nothing else is working, then the last resort is a wide local excision or a mastectomy. That has to be explained to the patient.
Any more questions?
Can I make a small comment on Dr.
Yes, sir.
Khalid's question that granulomatous mastitis, the ultimate diagnosis is given by a pathologist. Let me first tell. It is, I may be giving a clinical diagnosis of tuberculosis or whatever it is, but the diagnosis of granulomatous mastitis is done when you see a granuloma and already you are given the histological features. The question that comes is idiopathic, the worst. If there is a definite cause, already answer has been given. If it is not responding to steroids or methotrexate, you have mentioned, one has to know that there is something else is going on there. It not necessarily due to autoimmune etiology, it may be due to a lingering chronic infection. If it is not responding, flaring up, means you may have to go in and maybe excise that or whatever that. So this is what I feel so.
Thank you, sir. Any other comments? Sir, Dr. Shivaram, sir, the final comments, sir.
So, thank you, Dr. Naz. Wonderful presentation. I think this is a problem to all the clinicians. Many of these patients are unnecessarily operated. Many of them are on tuberculosis drugs.
Correct.
And, yeah, unnecessarily. And some of them give a small dose of steroids. They think patient is not improving and then they operate. So appropriate dose of steroids for the appropriate duration, once they make a proper diagnosis, is very, very important. And patient's cooperation in this is very, very important because it's a long-term therapy. Another, as you are presenting, I was thinking this is not a surgeon's disease at all. It's basically, most of it is physician's management. Surgeons are managing because they come to us. So very important that if you unnecessarily operate without your preparation, they will be stuck with us. They come back again and again. We also don't know, we get frustrated. Such things should not happen. So it's very, very important to diagnose idiopathic granulomatous mastitis from the other secondary granulomatous mastitis and treat accordingly. You have put a wonderful chart. I think this is very, very useful talk to every postgraduates and also practicing surgeons. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thank you, Dr. Nas, and all comments from most of the audience that it was an excellent presentation. And of course, from me too.
Yeah, thank you.
Thank you so much.
Thank you, sir.
Thank
Thank
you,
sir. Thank
Dr.
you.
Levani. Wonderful
Thank you, sir.
moderation.